This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.
Our interview with Dr. Etherington continues here in episode 3 of the MHAN podcast. In the first part of our conversation, we discussed at a very high level a definition for mental illness, the elevation of mental health issues, and explored the concept of the three-legged stool response here in North Dakota. In addition, we discussed financial concerns and need for filling gaps in services, and talked through the 211 program to help individuals wherever they reside in the state. We hope you enjoy this continued discussion and the current state of mental health services, responses, and needs in the community. Trying to analyze what the good, the bad, and the ugly, and everything in between for that, where do we stand on how strong we are in different parts of the state when it comes to having crisis beds? We've got a lot of them, but
Yes.
Where are they located, and in what sector of the state do you find them to be the most robust and the ones that need a little bit of extra TLC?
So we have those beds in Williston, Minot, Devils Lake, Grand Forks, Fargo, Jamestown, Bismarck, and Dickinson. Where at the moment we sometimes are limited is because of COVID. Sometimes those 16 beds end up to be 8 beds, depending on the structure of the facility and the need for single rooms. So that is one limitation during our pandemic that sometimes I worry about, in part because the demand is up, hospital beds are full, and we'd really like to defer from unnecessary hospital. And yet we are sometimes limited in the numbers of individuals that we can accept and have in those beds at any given time. Okay, so that is limit. I think that in addition, there is a culture shift. And so we are still in the infancy of shifting the culture to believe that they could have a place to call, a place to go, or somebody to respond in lieu of going to the emergency room or in lieu of calling law enforcement. And so I believe that requires a lot more education, community education. Part of why I'm happy that you guys invited me today, right? We need to get the word out. We've done a lot of education to law enforcement. We've done it to professional groups. But as some of my dear colleagues have reminded me, Rosalie, you're not hitting the right people, right? Because you're not hitting the people in need. You're hitting the people that might interact with the people in need, but you're really not communicating to the people in need. We need to get that. We got to get the word out to the people in need. And I hope I answered that question. I'm not sure I answered the whole question.
So I guess to delve into it, like when you have somebody that's experiencing a crisis and they need a bed, and we're going to, again, stipulate these are adults, and they're from very rural areas, what does that look like for the ability for people to do that and
Absolutely.
The struggles that is apparent?
I think one of the obvious struggles might be transportation, and then transportation in context to how acute the issue is. So somebody in crisis that might be safe enough to travel with family and have the means to travel, have the means to have transportation, then it might be pretty simple for them to get from a rural area into the city so that we can assess them and make decision. And if they need a crisis bed, that they get one. Sometimes, however, people do not have a means of transportation. So what does that look like, right? Sometimes based on the very rural area and the emergency of it. So say somebody is at such high risk for killing themselves, then unfortunately, sometimes they end up in a police vehicle, right? And that's not very comfortable for people. And yet from a safety perspective, right, much better that they're alive and escorted by the police to the CRU than to never get there at all. So that is an absolute limitation and some issues in our state and have been longstanding. And so we're hopeful that a few things. First and foremost, I believe we have 38 critical access hospitals in our state, and they are in much better proximity to many of our rural communities, and so individuals can get to those places a little bit easier than they can get to the 8 major cities. If they get to those places, we can do intervention as much as possible via telehealth, and many crises could be resolved so that people don't have to travel any further. That's my one wish. In the event they have to travel further, then we at least have them in a place that's safe so that we can figure out what transportation should look like. And can that be family? Could that be an ambulance? Would that have to be law enforcement, as last resort? But at the very least, then the first response would not be a law enforcement response, but instead, right, another medical facility.
So I'm sorry, Patrick, I was going to go first because this immediately popped in my head when she mentioned the rural limitations. What kind of staff are needed in these receiving facilities? And is there a way to have those facilities in those very rural communities?
So when we consider the crisis of receiving and stabilization facilities, our staff, it's very, very important that our staff are highly trained, because now we expect of them to be managing, observing, treating individuals in a fairly acute stage of potential mental illness or crisis. And so when we talk about suicide risk, when we talk about violence risk, when we talk about acute psychosis or severe depression, then we are training those individuals in what we call emergency response. So in the event people get very dysregulated and need to be calmed, we are training them in risk assessment so that we make sure that individuals there that are at suicide risk are very safe. We're also making sure that those facilities are constructed or renovated in a way that we don't have hanging points, that we don't have other risks for suicide, because it has to be a very safe environment. So having identified all of that as need, it would be a very expensive endeavor to consider even building any of these facilities in every county of our state. And then when you consider having to staff these with highly trained individuals, I cannot see us having it in every county of our state.
Is there cross training between police officers, sheriff departments, other professionals across the state who are, maybe front line to being last resort, getting a person in crisis from point A to point B? Is there plainclothes officer training? Like how does that work? Because I would imagine that, it's a numbers game with people, right? It's a numbers game to access for that. How closely do you work with first responders to crisis train to transport? Because you're in a state this rural, and that transportation is just the one that's blinking in my brain as the most important piece to this. How closely do you work with them?
We work very closely with them. So interestingly, and I think because we are so rural and because our law enforcement officers have to respond in so many different situations, I am frequently impressed with their capacity, their ability to actually manage human crisis. Mm-hmm. And so although some of them are formally trained, some of our officers in the state have received CIT training, for example, to respond to behavioral health crises, not all of them have. And yet some of them intuitively know what to do, and some of them, just by the nature of the job, I think, have fallen upon the skills or developed the skills over time to do it. So part of our job with them is to not only be good partners and to not just be available to them, but for consultation, but to also be available for good, warm handoff. So we have to be in the right place at the right time so that they can do that handoff quickly, and then they can get on with their other duties.
And so for the adult section, I mean, a lot of these questions are going to be mirrored for the adults with the children, but a question that we have received and we are going to ask you is, how has open access helped people in mental health crisis? And if there is a pretty good response you have for that, could you describe what open access is?
Absolutely. So open access is a clinic management technique, for lack of better terms. And what that really means is that a person in need may walk through the door and receive it, okay? Depending on what that need is. So when we set out approximately 6 years ago, 5 to 6 years ago, to examine this as a process in our clinics, we said we would want an open access so that anybody could walk through our door, we could assess that need, and we could provide it to them without a waiting list, right? And mind you, when we started on this path, our waiting list for assessment could be sometimes up to 6 weeks, 12 weeks. Our waiting list for service could be as long because, again, we didn't have good process in place to make sure that we could see somebody immediately, assess their need, and get them in service immediately. So it really required us to restructure our clinic services and how we do business, okay? So then person could walk through the door, say, I need an assessment or I need psychotherapy. We say, okay, let's have you see a clinician. We do what we call a diagnostic assessment, which is essentially assess for care. And we say, yep, you know what? Let's get you to see a psychotherapist and let's start today or let's start tomorrow. We got your appointment ready. Hey, we'll see you next time. Okay. It can be that seamless. What we found in the beginning was that we could develop that in part and have open access, but not every day in our small centers, just because of the volume of need and the numbers of staff available. Because mind you, you have to do this while still seeing all of the clients on your caseload. So you have your ongoing clients that are already in care, and then you have the new possible clients walking in. So what we did a couple of years ago was also through telehealth, do what we call hub and spoke, which is now we centralize the process of assessment so that if anybody walks in to any one of those clinics, Monday through Friday, 8 a.m. to 5 p.m., they will be assessed and we will immediately start care, okay? What we do, though, is we do it by way of a telehealth platform so that if the clinician in Williston is already deployed assessing somebody, then the next clinician on board in our telehealth platform will pick it up. So that clinician might be in Fargo, but now she's going to do that next assessment in Williston, and that then occurs seamlessly all day long, right? One after the other after the other.
One of the things that, just to add a layer of complexity to how you deal with crisis situations is specifically counseling or crisis service to persons with intellectual disabilities. How do you layer on top of an already crisis now an individual who may have an intellectual disability? How does that work, and how would you assess how you work on that currently?
So if we consider that in behavioral health crises, any one of us are not thinking as clearly as we usually do, right? We are a little more excitable. We are what we call emotionally dysregulated, which is like easily upset. That is, when you consider the range of that, an individual with an intellectual disability, for example, is not going to have the same verbal skills as others. And then in an excitable state, right, those verbal skills are even going to be less. So it does really require a unique intervention to make sure that we can resolve crises, right, and get the person in a better state of mind. So what we have done is twofold. We first trained our crisis response clinicians so that they understand the nuance, the individual needs of those individuals with intellectual disability, right? We've also trained them in youth and family intervention because that's also a unique need. So when they respond to individuals with intellectual disabilities, right, then they are going to be better equipped to be able to know how they need to approach that crisis intervention and how they need to simplify their interaction, right, to make sure that it's successful. Then in addition, we have deployed the assistance of a lot of our specialists in what's called CARES. So the Life Skills and Transition Center, which is our state-run intellectual, it's a residential facility for individuals with intellectual disabilities. And they have a set of staff that are very specifically trained and community providers to now do a secondary response. So we do a warm handoff to those individuals who then that next day would follow up with a phone call and could come on site to either the facility or the independent apartment and do that secondary intervention to make sure that the crisis remains resolved and to evaluate, look, how do we prevent any future crises? What can we do as far as the plan of care or as support to provide for you so that we can prevent the next one?
Finally, just to kind of summarize some of the issues that people have been perceiving over time in the state of North Dakota, do you have kind of some additional comments or a good way of focusing the narrative on where we are in terms of a Western versus Eastern divide in North Dakota when it comes to access to crisis services and the quality of it? It used to be very well known that the Williston, Bakken region struggled heavily with mental health services. So where do you think we are with that?
We are, it is very apparent that we have a lack of services in the western part of our state, particularly when you compare it to our east, right? So that is coupled with the fact that our population has grown so dramatically in the West, and service providers and the expansion of services has not kept pace with the numbers of new residents. So that in and of itself compounded an already shortage area. So we were already short services, right? Then we got more people that moved there. Now we're even shorter services because we didn't get providers to move there with them. So unfortunately, there is a dearth of services right west of the river. Now, having said that, I do know that there are a few more providers, both in the Williston and the Dickinson area than there would have been 5 years ago, but there's absolutely not enough. I know that the cities have been in multiple conversations with other providers, hoping that they can attract more expanded behavioral health services, private providers coming into the city. Again, not yet occurred. So I know from our perspective as public providers, we have had to do a lot of work in supporting our very small human service centers in the Williston and the Dickinson area, knowing that we also can't recruit staff sufficiently to meet all needs. So then again, telehealth has been a godsend because we can get some of those professional services in there when we can't actually recruit a psychologist or a psychiatrist or even a licensed independent clinical social worker. So I do believe that some of our other providers have also started to provide some telehealth, still just yet not enough. We also know that there are no psychiatric hospital beds in the Williston or Dickinson area. We've been in conversation with our private partners for some time, hoping that they will consider the opening of such beds, and that Dickinson, CHI Dickinson has now, through their corporate office, received authority to do that. The trajectory of that, the timeline is unknown to me, right? So again, you got to build beds, you got to staff beds, but it's very exciting, right? It's very exciting to consider that we may have psychiatric beds in that area in the near future. We used to have psychiatric beds there way back when, but not for a very long time.
Well, as you eloquently alluded to and set up nicely for the sort of finale of this particular podcast is the real challenge of crisis response system for children specifically. And I think we kind of take that three-legged stool approach here in this final part of the conversation, which is, can kids call 211? And what happens when somebody on the other line sees that it's a child?
Absolutely, youth can call 211. And the person on the other side, other line, when they may understand that it's a child, will provide that service regardless. So any youth in crisis may receive a service without parental consent. So I think that's important to know for any young person, anybody under age 18, right? They can call, they will receive a service. We will help them. They can also walk into a human service center and receive crisis services, crisis psychotherapy without parental consent. And I'm not recommending that youth don't consider talking to their parents. By all means, if youth are able to talk to their parents, that's fantastic, right? And if parents come with them in the state of crisis, right, we will treat the youth and the family. However, in the event that youth is alone, doesn't have a parent close, or doesn't feel comfortable at that moment to ask their parent, they can still access the services.
And how do you communicate that to kids? How do you communicate in a state very rural and very, sort of all over the place, and telehealth kind of just rolling out? But how do you communicate with the youth of the state that this has, you have the ability to do this, how you can get access? You don't have to have your parents available. We can help you regardless to get you into a safe space. How do you communicate this to them?
Good question that I may not necessarily have a good answer to. So I think some of what we've done so far is had conversation with our teachers, our resource officers, and other personnel at the schools, and have done a really good job educating them to say, look, we're available, right? We can come into the school, or they can call us, right? And they don't necessarily need their parents involved, right? And yet, although that's good, I don't think it's sufficient. And so we really need to brainstorm what other means do we have? What could we do to get the word out better?
The state of North Dakota has developed over time a really sophisticated advertising campaign about getting help for behavioral health. Anybody that's used YouTube and I don't know, maybe has searched mental health related stuff on YouTube. I don't quite know how the algorithm works, but I've seen a number of ads on my daily YouTube streams where I'm getting those behavioral health ads. So that has helped tremendously. Just hoping that we continue to find new ways to plug into young people's atmosphere so they know that help is available.
And I think anybody listening to the podcast who has their friends in the advertising agency or the creatives that roam around this state everywhere, get this thing in front of them and then have them call Dr. Etherington and go come up with a plan that's creative to do that. That's my call to action for you in this segment of this thing. Get a hold of that, because I think there is a creative way to do that. I honestly think that this state is so creative in coming up with solutions, whether it's flood diversion or some sort of like these big things. We come together to do that. And I think the call to action on how do we get in front of youth to understand that there is a answer, or at least somebody to answer the phone and a place to go eventually is available. I'm convinced, glass half overflowing full, that there is a solution out there for that.
Well, and just to add some additional solutions that have been made available. There have been schools across the country, and I don't remember exactly where this was, but students came forward and said, hey, we want a solution to be done about this. And so what they did is, I think on the back of their student ID cards or something like that, they had the National Suicide Hotline and stuff like that on the back of their student IDs. So like basically as standard issue given to every student, on the back of it is a little call to help that here's a number that's available for you to call. So there are little solutions, both technologically advanced or not, that we have at our disposal. The maybe nerdy question that maybe has a very quick answer, maybe doesn't, that I have is, in the past, it had, as I discussed with the adult side for 211, there was some difficulty in getting providers to sign on to saying, hey, here's the services we provide, and we want 211 to have access to that. Has there been a similar trend in getting more children's providers onto that log, or are you seeing a divergence in you know, more adult service providers signing up for 211 than children's providers? How's that going with when it comes to children's services and 211?
So although in general there are more adult providers in our state than children's services, and so just by volume alone, there are more adult providers that have made themselves available and are on the network or the resource guide for 211 or for First Link. However, knowing that our human service centers have helped augment that list, then we had a more complete list by region for children's services in addition to adults. That has improved. So in general, we need more children's services, children, youth, family services in our state, everywhere, right? We have gaps in service. We have large gaps of service for youth and families.
As part of those gaps, do those gaps exist for the mobile crisis response teams, or do they adequately, as well as the adults, do they as well or adequately address and having the ability to operate for children as well as adults?
Yes. So our mobile crisis teams are trained in youth and family intervention and are equally available to respond for youth need, to respond to families.
Is there anything really unique about how a mobile crisis team responds to children's issues compared to adult issues? Are they meeting the children and youth in unique situations compared to adults? I'm wondering, how does this work with the school systems, stuff like that?
So up to now, what we have found is that many of our crisis interventions for youth have occurred at the school setting, or in the event they have occurred in the home, it has been due to family conflict, right? However, we are available to go anywhere where youth are for the purpose of those services. So we will go to the schools, we will go to a friend's house, we will go to their house, we will go to a homeless shelter. So anywhere where that youth might be, we will go. So although I don't think there are barriers to access, except of course for the rural areas in our geography, from a where youth are perspective, there should be no barriers.
Are you getting the word out adequately, do you think, about like this being an available service? Are school districts aware of it? I don't know who else, but I mean, the school system usually immediately comes to mind. How is the communication out to the public going about this being an available service for children and youth in crisis?
So we have done a lot of education. We have a variety of flyers. We have a website identifying all of our services. In my opinion, in spite of all of that, it's still not sufficient, right? We also know that this is a process, and we know that we need to continue to come up with creative ways to get the word out, and we need to get the word to more people, if that makes some sense. So we have educated schools, we've educated law enforcement, we've put up flyers. We know that people are accessing the website and identifying all the services available and who to call and when to call and where to call. We have done education for providers of services and hospitals and emergency departments. What I still believe, however, is that for individuals that might have need, that might have crisis, that aren't intersecting at a school level or a law enforcement level or an emergency department level, we still haven't sufficiently educated. And so that's a work in progress, I suppose I would say.
So that would seem to me like the general public
correct
response, because if you're working in the legal system, you're dealing with a child that has been in direct contact, extended contact with a given governmental agency or bureaucracy, and that's a good ticket into connection to the mobile crisis unit or mobile crisis teams. Whereas if you're just any other child or youth, it's difficult to get that word out.
Correct. Correct.
As far as the where to go aspect, right? And so, and speaking rural versus, sort of the urban center too, safe beds for kids, youth, children. If you're experiencing a mental health crisis, you got to 211, you got to talking. How do we have enough safe beds for the children and the youth in the state? Do you find that there is, like you said earlier, adult beds, we got them, but from a kid standpoint, where would they even go, and are there enough?
So safe beds, as we know them in the state, are really not available for crisis. Although some youth that access those beds might be in crisis. And what I mean by that is, though, that is a limited set of beds that are specifically for individuals that are in the child welfare arena. So very specifically, those youth that are in foster care. Okay. So therefore, they're really not available to the majority of the youth in our state. We recognize that we have a limitation. We have a gap in our services because we don't have a crisis stabilization bed or sets of beds for youth. So what we identified instead was that we do have facilities in our state. They are shelter facilities, and we are in the process of creating licensure for them so that they have staffing appropriate and safe so that we can, in fact, use those beds for crisis. And what that would look like, of course, is that we would provide the clinically trained staff to assist, right, respond. In the event we respond to crisis of a youth in a family setting, crisis isn't resolved, we need a respite, right? We need a separation from family. Then we're hoping that we could use those Shelter Plus beds for that purpose. And then we make ourselves available to Shelter Plus in the event we go back into the facility to do other intervention, if that makes some sense. Mm-hmm. Not yet available. Those are not yet licensed. Those will be licensed within the year, right? And then we will be working as partners to make sure that they know we're available. How can we access? How do we do this in partnership?
And I'm going to ask or lead into a slightly uncomfortable discussion. For people that might be aware of the current discussion about those facilities, there is a lot of confusion / concern about where things are going to head with children who are now labeled as children in need of protection, children in need of services, and the population that we're referring to, children that are experiencing a mental health crisis. I know that this is a very sensitive topic, but how are the discussions coming along in terms of ensuring that providers that are providing that service feel comfortable in being able to provide that service, that different governmental entities are doing what they need to do to provide a safe environment for everybody and an effective environment for everybody. I'm just kind of wondering if you're able to get a sense of where things are headed with some of those issues.
Well, Matthew, I'm going to preface this with saying I might not be the right person to ask, and I might not have all the information, or even what little information I have might be not accurate, right?
Yep.
What I know, however, is that for youth that are arrested, for example, and maybe under the custody of law enforcement, then it is necessary that they be separated from all other youth. Okay. And I think that is some of the dilemma or some of the concern about how would that separation occur in those Shelter Plus beds reasonably, right, and safely. What I know is this, that I have been a part of a task force that is looking at interventions before an arrest, before law enforcement intervention, with hope that many of those youth that have in fact been arrested don't need to be arrested, that we should be responding with our mobile services to the home to manage those crises, those interpersonal conflicts, so that that youth does not get taken from the home with law enforcement under arrest. So although as we respond, maybe we resolve crisis, or maybe the parent and child still need separation, then we as a mobile team would facilitate that youth going to that shelter plus bed, but not under law enforcement custody. Therefore, no separation is necessary. So that those are our discussions now about, look, how do you access this service? How do we make sure it's available when needed? And then we can avoid law enforcement response when at all possible. I would imagine then we do this successfully, all that number shrinks, and maybe there is no longer a need for those beds for law enforcement.
So if I can summarize it in a general sense, there's a lot of reforms going on across our human service and judicial systems right now. And it's a bit messy, a bit complicated, and sometimes a little controversial. Do you feel like our state has the capability to navigate those contentious waters and kind of maybe not make the perfect system, but come out the other end ahead in being able to provide just regular services to people sooner than later, and be able to address crisis services for these children at the same time?
Absolutely, yes. And may I say, human lives are messy. We're all messy. So I don't expect within the realm of my work, which is human services, to be nothing but messy. And yet messy doesn't mean it can't be better, and it doesn't mean we don't do good work. And I think we do incredible work in North Dakota, and we still have way more work to do. So I do believe that we can navigate these waters. I do believe that we are making a better system. I believe we're making a better system for youth and families. And there are so many exciting things going on now, right? So if you think about all the puzzles of need, right, and each piece is coming together. When I consider the system today and services today and the youth that I help, and I look at that 5 years ago, huge difference, so much improvement, and we have more improvement to make.
So the overall picture for the crisis response system, would it be fair to say that for adults, things are substantially better off than they were 3 to 5 years ago in each of those stools?
Yes.
But if there are gaps identified, where do you think the strongest gap is? Is it the crisis beds or the mobile crisis units, or are there both very equally kind of needing attention? How are you weighing this as a public official?
I believe that the larger gap for adults is the mobile crisis response and the limitations we have with the miles. So knowing that, right, we can catch a lot of people and we can be available to a lot of people, but with that limitation of the 45 miles, I know that there are gaps outside of that. And I also know that although we are partnering with our critical access hospitals and our other hospital systems, it's still not yet fully functional, available, or known to such a degree that people are actually accessing it like they should. So I consider that the largest gap, and will continue to work. For children, right? I'm sorry.
No, continue.
For children, in my opinion, the larger gap is the lack of a place to go. So although we have the same limitation for youth and families within that radius, right? We have that limitation. In addition, we have the limitation of not having a place to go, and we know that we need to get something. So right now, if a youth has crisis and we are trying to resolve the crisis in an in-person response, but yet if they need a place to go, we don't have an option available, that's a huge gap.
In terms of a timeline to addressing these issues, what should the public be looking for in terms of when things are going to start coming together for the children's system with the crisis beds?
Oh, absolutely. So, and I'm going to apologize if I get this wrong, because not in my wheelhouse. However, it's my understanding they are working on the licensing procedures now for those Shelter Plus beds, and that it would be the expectation that by this summer, they would be licensed. So I would anticipate that let's just say by August, if they are all licensed and we have sufficient beds available, then I would think by late fall, by October or November, that partnership should be solid enough, right? Their staff should be trained sufficiently, and then our staff available for assistance, that we could be using those beds for youth in crisis.
And do you think by the fourth quarter of this year, can you give an estimation about how many communities would maybe receive those services? Is this like a regional, statewide effort? What is this looking like, if you know?
I don't know.
Okay. That's okay.
You know what I think I love most about this, and I think it's especially acknowledging the gaps within the children's services for crisis pieces, is that it never stops with, and that's what it is, right through the period. There's always an additional, not only recognition of the gaps, a recognition that this is messy, a recognition that this is this transition of trying to create from whole cloth something that we were realizing that needs to happen, especially on the western end of the state and how rural it is. There's always a glass half full with the solution just around the corner as we sort of put our feet sort of in motion to move forward. And we all know that, no money, no mission. The more money we can put through to this, the quicker that this solution can go. And I think you've given and laid out so many reasons for supporting this in massive quantities, right? There's never been a plea through this entire conversation of like, if only we had money. You've given the whole route that everyone listening to this can see the solution if they just write you the check in order to get this done. And I think that's really what the more remarkable piece is that you've taken the roadmap and the stool from adults, recognize that there's gaps with kids, that it's the same result. It's the same 211. It's the same having trained professionals who have the ability to go out to the communities and do this. And if we expand the amount of mobile crisis units, we expand the opportunity to get to as many people as possible so we can stop the next step of getting them into a place, even though we have the places and we need better places. But you've given this particular roadmap. And I think that's what's so incredible about this particular crisis conversation about mental health crisis and what we're doing about it. I think you've laid the groundwork out beautifully to give everyone who's a decision maker to listen to this and say, oh, well, let's just fully fund everything that they need, because then we can get this done as quickly as possible. And I think that's just such a remarkable thing to have not only lived the experience and to see this from the ground up, but given everybody a chance to just say, yep, we got it done. Let's just trust this whole group to take this and run with it the way that they've done with the adults.
And Patrick, I'm going to continue with what I did in the last episode, which is I ended up finding out that I ended on a little bit of a call to action note. With the state hospital, it was the appearance of the barbed wire all around the campus. And this time it's going to be a call to action to realize that statistically from 1999 to 2016, North Dakota had the highest growth of suicide in the country. The highest growth in the entire United States of, I think it was 57% or 56.7%, somewhere in there. That's the call to action. We have a serious issue on our hands, and we have the capability to deal with this.
Yes.
Dr. Etherington, thanks so much for being a guest again on the podcast. Great in episode 1, even probably better in episode 2. Just your insight is so remarkable, and your ability to explain these things from very complicated clinician sort of concepts to things that I can understand, which is always the benchmark of how things go on the podcast. But thank you so much for being a guest again. Your answers are so clear, they're so concise, and they're so wonderful to comprehend. And again, that roadmap is so beautiful to prevent these numbers from even climbing higher, that Matt just said. So thanks for being a guest again.
You are welcome. Thank you for having me.
This podcast is brought to you by the Mental Health Advocacy Network. MHAN advocates for a consumer, family-driven mental health system of care that provides an array of service choices that are timely, responsive, and effective. Our vision is for every North Dakotan to have access to the right service, whether it be preventative, treatment, or recovery, at the right time, when the service is needed, and at the right place, as near his or her home as possible. To learn more about MHAN, our advocacy efforts, and literature about the North Dakota mental health system, visit our website at www.mhan.org. Again, our website is www.mhan.org.